Berkowitz earned his veterinary degree from St. George's University, and he did his clinical year at the University of Illinois. He completed his rotating internship at Berg Memorial Animal Hospital of the ASPCA in New York, and he completed a 3-year residency in emergency and critical care at Oradell Animal Hospital in Paramus, New Jersey. He's a board-certified emergency and critical care specialist, and he's on the critical care team here at NorthStar VETS. He has special interest in metabolic and endocrine emergencies and management of septic patients. He's also a fascinating guy. He's appeared in seasons 5 and 6 of the TV show Animal Precinct. He's on the board of trustees for Mickey's Kids, which helps provide service dogs for children in need. He's on the board of diversity and inclusion with the College of Veterinary Emergency and Critical Care. He's also involved in reviewing the latest RECOVER guidelines, which is a big deal, and that advances evidence-based CPR practices. And he also gives back to the industry and community in other numerous ways, but I wanted to keep it concise. But he's a super awesome dude and an excellent speaker. He's got a great presentation for you guys tonight. So without any further ado, I turn the floor over to Dr. Stephen Berkowitz. This will get you forward slide, back a slide. All right, good to go down.
Good. All right, everybody, thank you for coming. It is nice to see faces instead of just computer screen. Those that couldn't come, I appreciate you joining as well. I said a little earlier, I'm going to try not to swear, but I sometimes get a little too cavalier during my talks. If there are any questions, you're not going to throw me off if you want to ask in the middle. Otherwise, I'll be available at the end as well. And for those of you on the video line, Phil will gather up those questions if needed. I'm going to lower that volume again, though, so that we don't need to hear everybody coming in and out. No, I'm not. Okay. All right. So thank you for joining us. I'm going to talk about trauma, which is something that is near and dear to my heart. I love trauma cases and I love trauma patients. So one of the reasons it is so important at tertiary hospitals and places like NorthStar VETS, 11 to 13% of all the patients coming in through the door are going to be trauma cases. And if you notice, it's the second leading cause of death in dogs, both below 1 year old and over 1 year old. So that is a pretty significant population. When you look at the studies, albeit not as many tease out euthanasia, the mortality rate is between 10 and 20%. So anything we can do to improve that mortality rate, anything we can do to help these patients a little bit quicker and a little bit more concisely, the better. So these are some of the things we're going to talk about. I do have some slides in here that I'm going to kind of breeze through quickly. Some of the scoring system slides, I have them in there for reference for you, and you can access them as well. So triage itself, it is a French term for sorting. And essentially the purpose of triage is to show up on scene or in hospital and be able to sort of stratify the patients. Who needs to be seen now? Who needs to be put sort of to the back of the line? And unfortunately in battlefield, who needs to be left there so we could focus on someone that we can help. But again, the purpose is to prioritize the patients as well as direct resources the best we can. And so one of the reasons that I'm going to talk about scoring systems, if you do not have some sort of system, we all may be looking at the same patient and stratifying them in different ways, and we may be separating them out in different ways. And I may on Monday call something a major problem and Tuesday and not that big of a problem, which is the intra-rater portion of that. So if you have a way to provide an objective mean to know who's who and what needs to be dealt with immediately, that's ideal. And that objective score should reflect the severity of disease, ideally in a numerical fashion, so it's easy to understand. And that is what VetCOT, which is the Veterinary Committee on Trauma, is doing. Right now, we are one of the few hospitals in the country that are a trauma hospital. What we do is we log all these patients and a lot of these different scores and what the outcomes were and things of that nature. That is being put into a system, and since 2013, I believe is when it started, there's over 56,000 entries in there. So we will finally have studies as big as human medicine where we can actually say not an N of 30, but an N of 3,000 dogs that were hit by a car and sustained thoracic trauma did this. But again, that's why we have these scoring systems, because it can make things like this much easier. So again, it's to provide information to help us decide who needs attention, but I do want to make it very, very, very clear. Do not use these scores to decide whether or not you're going to help a patient. And do not use these scores to tell a client there's no hope because you rated a number 2 or a number 4. They're helpful in the sense of allowing you to say, in general, a patient that hits this score has a guarded prognosis, as opposed to give us some time because this is a good prognosis. And so long as we could figure things out, we have a better chance of getting your baby through it. But please, it is super important to me that we don't use that as a, hey, your dog has this score, don't bother. So some of the things that we're going to talk about are the Modified Glasgow Coma Scale. Humans, they have the Glasgow Coma Scale. We've modified it for our pets. AFAST and TFAST scores, those are bedside ultrasound, looking at our chest and our belly. Some of the prognostic blood values we talk about, and then animal trauma triage scores are also important. I'm going to focus on Modified Glasgow and the blood ones, because that's something that we all have available to us at all times, as opposed to some places don't have bedside ultrasounds and some of the other things that you might need. So the Modified Glasgow Coma Scale, it is 3 separate sections, 3 different categories, and you grade them on severity from 1 to 6. The higher the score, the better the outcome. In people, the scores are 1 to 3. The human version is what we've all experienced, hopefully not primarily, but when you have head trauma or you've been in an accident and they ask you, do you know where you are? Do you know what day it is? Do you know what month it is? The reason they're doing that is they're trying to figure out how aware you are and what your mentation is like. So we can't do that directly. So we've augmented their scores to make it more applicable to pets. So the first section we look at is motor activity, their gait, their reflexes, their responses to things in the motor end. So what we know is that if you have hyperreflection in all 4 limbs, we're talking about cerebral damage, okay? Whereas if you have variable flexion extension, front and back, that might be more of a cerebellar injury. So it kind of helps us already figure out within a couple seconds, quite frankly, of a patient coming in, where they stand on that. Important to note, that patient that you see that radiograph there has a broken back. I cannot use the Modified Glasgow Coma Scale in that patient as freely as I can with a head trauma per se, because that dog for sure is not going to have motor function in those back legs. But if they have a normal mentation and a normal response, PLRs and things like that, that score is going to be way different. All right, and so next section is our brainstem responses, your pupillary light reflexes. So your pupils are very important. And again, I even have a little section there in the absence of ocular trauma. If you have a patient who got poked in the eye and that one pupil is myotic, it's going to change your score if you don't take that into account. So again, there's limitations to all of these. But if they're myotic and you have pupillary light response, that's a great thing. That's a very good sign. It lets you know that your brainstem is functional, your cerebellum is functional, and some of your cortex as well. If they have mydriasis, then we start to worry about midbrain. All right. Technically speaking, forebrain as well. If they have fixed pupils that are not responding, fixed mid-range pupils, that's very bad. What that tells us is either you have severe global brain injury or you may have even already herniated. So that particular instance is one of those times where it is worth talking to the family of, look, this particular thing is very dangerous. We know that you have at least a major trauma to your brain. All right. The oculocephalic reflex, so that's when you're tracking things as you turn your head. The eyes should be following you, but they're not going to be a straight back and forth movement. And so we will move their head back and forth. If that's intact, that lets us know that our brainstem is still functioning appropriately. So that's another guy that's very important. The last one is level of consciousness. So in people, that is the #1 predictor of your brain trauma. And that is why they ask those questions almost immediately in the EMTs, and then when you get into the emergency bay, and then the doctor again when you're in a room. Your awareness of where you are and what you're doing lets you know that the ascending reticular activating system is intact. So you're processing things appropriately. If they're comatose or they're not able to respond at all, that lets the physician know that they have serious brain injury. Again, it doesn't tell us if it's irreparable, but it does let us know how severe the brain injury is. That is my cat. She does not have brain injury. She was just being a cat. So this brings me back to the limitations and the scoring. Again, not every patient has symmetrical pupils. You may have a cat that has synechia from, an eye issue from when it was a kitten and now it's 10 years old. So that's going to throw things off. Not every patient has paraplegia, paraparesis, tetraplegia. It might just be one arm. It might be radial nerve neuropraxia. So you have some things that you just can't fit neatly in there. The recommendations VetCot is to take the lower of the scores and use that. So for instance, if 6 is perfect, but they have something that's a little off, then 5 instead of the 6. And those numbers themselves give us information. And what we found with a few different studies is that if you are constantly tracking these scores every 2 to 4 hours, it will help also know how you're performing. So when I have a severe traumatic brain injury patient, I mentally figure out their Modified Glasgow Coma Scale when they come in. And then after I do some therapy, and then again in the morning, and I actually will talk to the owners and say, hey, Fluffy came in with a very guarded prognosis because of this score. We've now jumped up to a better level. So we're showing signs of improvement, and this is a numerical objective improvement. So give us more time. Let's see what we can do. Early goal-directed therapy. So that is something that we've sort of shied away from using that term, but what it is an assertive effort to try and fix shock within the first 6 hours of presentation to the emergency room. For those of you that like the Rangers or Flyers, Dr. Hammer, you will notice that there is a New Jersey Devil there celebrating. Probably beating the Flyers and winning a Stanley Cup. So this is a paper in the human field. This is from 2001, Rivers et al. This was a groundbreaking paper. This is the paper that described this early goal-directed therapy. They found that when they made this assertive effort to fix certain parameters within the first 6 hours of admission, the mortality rate dropped by almost 30%. And that's huge. It's a 6-hour window, and we've improved odds by 30%. Things that they looked at in there, some of them are very easily accessible to all of us. Some of them are more complicated. For instance, your central venous pressure. You need a jugular catheter. It needs to be placed in the exact right position between the 3rd and 5th vertebrae or rib space. They also are wrought with problems. If your patient has chest trauma, pleural effusion, they're not great. So we've shied away from those, but that's an example of something that we're not going to have all available. Central venous tissue saturation is literally taking the arterial oxygen saturation in the right atrium. Obviously not something we can all do. So what is shock? Why is it so important, and what is actually happening? So us nerdy criticalists like to talk about oxygen delivery versus oxygen consumption. DO2 is delivery, VO2 is consumption. Essentially what it's telling you is this: you have circulating red blood cells, you have cardiac output, so your heart rate times your stroke volume. You are going to deliver as much oxygen as you need to get to those tissues for them to function. So long as you have appropriate oxygenation, appropriate red cells, appropriate perfusion, your oxygen delivery is going to match your consumption. When you are in shock, by definition, your consumption is higher than your delivery. Doesn't tell you why, but that is by definition shock. You're not delivering as much oxygen as your tissues require. So if you were to draw it on a graph, you see here I am just going to do a thing that I'm not supposed to do. I'm going to walk over and point to it because I don't have a pointer. So this is the oxygen consumption on this line. This is our oxygen delivery here. If you notice, you have a linear relationship and you get to this certain point where you no longer are matching. So that particular point is called the critical DO2. That just is telling you that at that physical point, that's where your delivery and consumption do not meet each other. It's a fictitious representation. It's not something you can physically check, but that is just an easy way to sort of visualize it. So when you have reduced cardiac output, or you're not delivering oxygen the way it needs to be, you're going to get poor perfusion to your tissues. So your oxygen level is going to be low. That's going to lead to cellular hypoxia, cell death, which then leads to organ death, which then could lead to patient death. These are some of the categories of shock. In trauma, generally, we talk about hypovolemic shock. They're either bleeding or they're moving fluids to different areas. We'll sometimes see distributive shock, which is wherein they actually have delivery, but they're not using it appropriately. And that would be, for instance, a septic patient. They may actually have normal circulating blood volume, but not able to get their fluid to where it needs to be. Lactate, that was something that we used to focus on back when I was younger, that if you had a GDV come in with a lactate of 6, it's a horrible prognosis. Just have the owner stop. We've now learned a lot more about that. It doesn't work that way. What we found is so long as you can drop that lactate down by at least 50% in the first 6 hours, the prognosis is markedly better. Why is that? So lactate production, when your cells do not have oxygen, they go into anaerobic function. Your pyruvate cycle switches over to form lactate. Why lactate? Because your cells can use that. It doesn't need oxygen, it can use that lactate. But the problem is, it's a marker of anaerobic metabolism. So it's a marker that you are not oxygenating your tissues well. And so the longer that's persisting, that is telling you that you're not doing a good job with perfusion. Ideally, you want to get your lactate below 4. In the RIVER study, again, all the lactometers have different numbers. In our epochs here, we use 3 as the high end of normal. And I don't need that number normal. I just want to see it coming down because that's a good marker that I'm doing my job. Hyperglycemia. Blood sugar is seemingly a strange thing to be looking at with trauma, but what we found is that hyperglycemia is something very common in critically ill patients. And in humans, and separating out trauma, up to 71% of humans in some degree of shock with critical illness will be hyperglycemic. The reason is complex and not very well understood, but it's probably a combination of altered fluid balance, cortisol being through the roof, epinephrine, some of the other issues that can cause your sugar to go up being abnormal. What they found is when you are hyperglycemic, you have increased risk of mortality. Again, these are some of the things that can cause that hyperglycemia. The reason it's dangerous is when you are significantly hyperglycemic, you increase the risk of free oxygen radicals, which can cause continued tissue trauma. We seem to feel that there is an increased risk of infection when you're hyperglycemic. If you want to take it to a more common thing, we know our diabetics are more often getting urinary tract infections because they have this really dilute urine with lots of sugar in it, and bacteria love that. So we suspect that's probably why they're more susceptible to infection. You also do see cerebral acidemia when you have significant hyperglycemia. In people, they do what's called a euglycemic insulin clamp. They'll literally put you on an insulin CRI and try and keep your blood sugar between 120 and 180. Used to be 80 to 120, but they found that they were making too many patients hypoglycemic. We haven't proven in our patient subset that it makes a huge difference. It's more of something that you track, but it is something in people they'll do. You might hear that term euglycemic insulin clamp. That's what they're referring to. So some of the things that I want to talk about: damage control. We have patients that are in shock. That means they're getting poor delivery of oxygen to their cells. With our dogs, they almost invariably have poor blood flow to their kidneys. So they already have an acute kidney injury in that sense. We have reduced blood flow to our brain at times. We have reduced blood flow to other organs. Because of that, you want to avoid anesthesia the best you can. We all know that even your healthy spay and neuter, when you put them under anesthesia, you can cause reduced blood flow to the kidneys, reduced cardiac output, lower their blood pressure. So we call it a second hit. You now have this trauma, you have poor perfusion, you have poor blood flow to your kidneys, and now we just put them under anesthesia. We hit them a second time. So damage control is the theory of do everything in your power to stabilize a patient before considering anesthesia. We're going to talk about some of the ways we can do that and some of the times that it's just not possible. So diagnostic wise, I don't need to run a CBC chemistry light panel and 52 radiographs on every trauma that comes in. Try and limit your diagnostics in the sense of what's important for that patient stabilization at that time. Make sure that their blood pressure is stable, at least a mean arterial pressure of 65. Why? That means we're perfusing our kidneys. 90 is ideal because that means we're perfusing our brain. Above 90, you can get a little bit trickier. We talk about something called low volume fluid resuscitation. In a patient that is actively bleeding, we unfortunately learned this from our soldiers out in the field, when they have experienced like an IED explosion and they have a massive leg wound, for instance, they found that if they blasted them with fluids, blasted them with blood products, and their blood pressure was normal, they bled more. So what the goal of low volume fluid resuscitation is, keep that blood pressure somewhere between that 60 to 90 mark so that we're getting good perfusion to the vital organs, but we're not blowing clots off things until we can get to surgery. So that's where that's coming from. In dogs, ideally heart rate less than 120. And once it goes over that, we start thinking that we're still potentially shocky. Cats less than 200. That number doesn't always work because my cat right now, if I put him in my car, would probably be 240. And if I have a Great Dane, I definitely want less than 120. Whereas if I have a Chihuahua, I'll accept 140. So again, there's limitations to these guys. Urinary output, central venous pressure, that central venous oxygenation, those are the numbers you would ideally look for. Ignore it right now. If you cannot get that patient stabilized, no matter what you do in these therapies that we'll talk about shortly, then sometimes you need to say, okay, we need to go in. We have to do it. With abdominal trauma, if you have a traumatic hemoabdomen, your pack cell volume is 40 when it comes in. 2 hours later, it's 15. And you're pouring blood products or pouring fluids into them. They're not stabilizing, you may need to go in. We had a patient about 2 years ago now. This poor dog was stabbed in the chest because of a dog fight in front of an 8-year-old girl. Came in stable, developed a pneumothorax, then had a continuous pneumothorax, and then started pouring blood into her chest. We gave her about 3 units of blood, and then we said, forget it, we're going into surgery. So there are times where you just cannot keep up. Try everything you can, but if you're not able to, then you ought to alert your surgeons. Thoracic trauma, similar. Do everything you can to stabilize that patient. That dog there is Mai and his brother Ty, so Mai Tai. That particular dog sustained severe thoracic bite wounds. He had a flail chest. He had multiple punctures in his chest, and he was extremely shocky when he came in. He never needed surgery on that chest. We chest wrapped him the best we could after we did a quick clip and clean. We flirted with chest tubes. He ended up not needing them, and we treated him medically, and he never needed to have that chest opened. It's an example of severe trauma, severe intrathoracic wounds and things like that, but we delayed and delayed and delayed, and we found eventually we didn't even need to go in. In his case, as you see, he has that nice body armor there. It is nothing fancy. It's just gauze wrap, cling, and vet wrap over it. Doesn't need to be anything fancy. Appendicular trauma, very rarely do these patients need emergency surgery. In fact, I can't really think of any in my recent times that I've needed emergent surgery. When you have a vessel that's pouring blood, start with your usual. Apply pressure, pressure bandage, however you want to do it. If they're saturating through that, sometimes you do need to give some degree of sedation. I would then use a local block and try and find that vessel and clamp it off. Doesn't need to be perfectly clean. Again, we're going to go back later and address that. But like I said, I've not really had a case that I could remember where we needed to go in for appendicular trauma. That particular dog that you see there stuck his arm under the neighbor's fence, and another dog did that to him. Again, this particular patient, we clipped, cleaned, wrapped. We dealt with that wound the next day. Embedded objects, we do see a fair share of, my own dumb pit bull would be a great example of where they have some sort of weird penetrating wound. They're running in the woods, you have wood jammed into their chest, or you have your hunting dog that got shot with the guy's arrow. Leave them alone, do not pull them out. Those objects may be the only thing tamponading that vessel. So it could be pushing up on that vena cava in the chest and keeping that patient from bleeding out. So leave the actual object there. Don't go yanking things out. If it is something that's very, very large, you can cut the ends and then wrap it. Be careful when cutting the ends. I learned the hard way because I didn't think it through. If you do not hold the object really close to the body when you're cutting it and you're holding it out here, as you're cutting it, you're doing this with it. So just remember to hold it close to the body and cut there. This is an example of another really bad case. This dog was here for big dog, little dog. She had head trauma. She was bitten on her arms. All 4 arms did need surgery eventually. She had what we thought, which thank goodness wasn't, penetrating abdominal wounds. She was in our ICU for almost 9 days, I believe. But even her, as bad as she looked when she came in, this is what we did on the first 24 hours. Clipped, cleaned, wrapped all these things up to keep them from getting dirty whilst in the hospital, and delayed surgery till she was stable. Here's an example of an arrow. I stole this from the interwebs, so I gave credit on the bottom, but as an example of sometimes you have patients come in that look totally stable, but they have an arrow going through their back and into their arm. Do not remove it, cut the ends, wrap it up. Cover the wounds with sterile bandages the best you can. When you are approaching a trauma dog, I remind my staff all the time, a lot of times they're covered in blood. It may not be the animal's blood, it could be people's blood, so remember to put gloves on. We're not going to get anything from the dog, but we may get it from the owner that has something. So when you see a patient like this come in, put gloves on. This particular dog was when I was an ER doctor before my residency, pit bull, shot through the chest, walked in, acted like nothing was wrong. Somehow that bullet, you can see the entry and exit wound, went through and through, didn't hit anything, didn't cause any major damage. The dog didn't even have a pneumothorax. I don't know how it happened, but that's great. That being said, we also know that high-speed projectiles will actually cauterize on their way through. So the vast majority of bullet wounds, other than small guys like BBs, don't necessarily need antibiotics because they are actually killing the bacteria and cauterizing it on the way through. Fractured bones. So ideally, we would want to put a splint on and limit the motion. If you have a fracture on a femur, like this dog, if we tried to put a splint on it, we're actually going to be putting pressure on that fracture. It's going to actually be a fulcrum pushing on it, so it's going to make it worse. The only way to do that is if you do a Velpo or like around the entire animal. So what you want to try and do is just try and keep them as calm and quiet as possible and relaxed. Drugs are your friends to help with that. If there is an open fracture, then it is worth clipping, cleaning, and putting a light bandage around that. just to keep from contamination. But again, this is not something that you need to rush to surgery. And people as well, you break your femur on Saturday, they're not calling the orthopod in until Monday. So it's same as in people. As far as blunt trauma, so this is a study from 2009. They found that those patients that had traumatic brain injury on top of other trauma had a significantly higher mortality rate by almost 20%. As you see, they're actually 27%. What they realized is we need to treat these patients very differently, and there's something different happening here. And so that's going to lead us on to traumatic brain injury. Your cerebral perfusion pressure, which is the blood flow that's being delivered to your brain, it's determined by two simple things: the patient's mean arterial pressure, so that's the blood flow going to where it needs to be, minus the pressure inside your skull. You only have about 10% wiggle room in your skull for expanding tissue, something called the Monroe-Kelly doctrine. If you have anything causing higher pressure in there, whether it be a bleed, a tumor, excessive CSF production, the pressure inside your brain is going to be high. And when that happens, the blood flow is reduced. And when that happens, you are no longer functioning appropriately. So what you want to do is maximize your mean arterial pressure. There's very few things you can do to relieve pressure on the brain. Do what you need to do to keep that mean arterial pressure, again, up around the 60s, 70s, 80s. And that should help with perfusion to your brain. Sometimes we need hypertonic saline or mannitol. There are some folks that feel mannitol is superior. There are some folks that think hypertonic is superior. I like hypertonic because it's very fast acting and its effects are within minutes. Whereas mannitol, being an osmotic diuretic, it does increase the intravascular volume a little bit, but that effect is 30 to 60 minutes later. Whereas hypertonic saline, as you're giving it, it's such a salty solution that it's pulling the blood into the vasculature, so it will rapidly expand your intravascular volume. It lasts about 30 to 90 minutes, the hypertonic saline. I will tell you, I double dip all the time. I'll give hypertonic saline, fluid boluses, and if they still look really crummy, I'll give them mannitol. When you look at the Modified Glasgow Coma Scale, this is where I was intimating earlier. If you notice that graph there, you see a huge difference between mortality and the score they have. And what you'll see is anybody with a score of 8 or above had a 50% increased chance of living. So that's why that score is important. And in later studies, this one was in 2001, they found that, like I mentioned earlier, that if you keep tracking it and it keeps getting better, 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 your prognosis is going to continue to get better. They found this under all circumstances of traumatic brain injury, from just being hit in the head with a golf ball to that patient that has depressed skull fractures. All across the board, these numbers still fit. Hyperglycemia and traumatic brain injury, this is one that we do actually have some good studies in animals. If your dog comes in with a traumatic brain injury and their blood sugar is 285 or above, they have a far worse prognosis. We don't know why. We don't know if that blood sugar is really high because of the trauma and they're stressed and it tells us that there's worse brain injury, or if there's such bad brain injury that they now have altered hypothalamic pituitary adrenal axis that is causing them to be worse. This is where that euglycemic insulin therapy kind of came into play, and people, they started controlling it. The reason the hyperglycemia is so dangerous is we know for a fact it causes worse brain injury, worse secondary injury. It has those increased free radicals. It has increased oxidative damage. Again, we don't know why though. So next step is, well, what the hell do we do about it? This is my cat Waldorf. Those are the little dolls that we gave away of Oliver and Shady. Most cats just play with things. He grabbed it like a tiger. So all of your therapy should be focused on perfusion and getting oxygen to where it needs to be. Resolve the shock. IV fluids are literally a lifesaver. oxygen support if they need it, blood products if they need it, inotropic support, meaning things like vasopressin, norepinephrine if needed, sometimes ventilatory support. I can't give you a cookbook. Treat every patient as their own entity. Do what they need at that time to improve it. So some of the things we can do are things like a shock bolus. So we learned in school 90 mil per kg for a dog, 40 or 60 mil per kg for a cat. Don't throw it all at them at the same time. Give a quarter of it, reassess. If they're still shocky, give another quarter. If they're still shocky, give more. My mentor at my residency said, these numbers don't necessarily mean anything. If your dog needs 120 mil per kg, give it to them. So be careful. You don't want to overload your patient because that will actually make tissue perfusion even worse, but you sometimes need more than what this tells you. Colloids like vet starch, there are some of us that don't believe in them, some of us that do. I happen to use them. I don't use them as a constant rate infusion, but I will use them as bolus therapy. We know in people it can cause acute kidney injury and it can alter clotting factors, but what we haven't proven in our species as well is it a long-lasting problem. So we know with fancy viscoelastic testing that yes, the clotting time, so the time to initiation of clot is reduced and or increased, meaning they bleed more, but it's transient. It goes away after 20, 30 minutes. And as far as acute kidney injury, we haven't proven that the colloids actually will do that. So I do use vet starch. Hypertonic saline, again, like I talked about, blood products. So in the human critical care conference I went to last year, they are shying away from fluids and they're using fresh whole blood. So what they're doing is you have major trauma where you're bleeding, they're going to give you a unit of red, a unit of plasma, and a unit of platelets. So when you have a traumatic hemoabdomen, for instance, sometimes you might just want to reach for blood products. I still start with fluids usually, unless they're literally pouring blood out. This is near and dear to my heart. I don't know why some of us will sometimes say pain is good for the patient, it helps stabilize them. It's garbage. You will never stabilize a patient that is in pain. Do not allow them to be in pain. You can do a quick modified Glasgow Coma Scale when they come in within minutes. See what their neurofunction is, then hit them with pain medicine. That dog that you see there with those severe burns, there would be no way I can get her to be stabilized without hitting her with pain medicine. Ideally, you'd want a pure mu, fentanyl, morphine, methadone. Why? Because I can reverse that fully. If you don't have them at your clinic, that's fine. Mixed opioids are also there. Buprenorphine is a very good drug. I can't reverse it all the way, but it is still a good drug. For me, butorphanol, yes?
Why the plus or minus that you're
So, good question. I find that that makes a lot of dogs pant like crazy, and it makes cats hyperthermic. And yeah, those are transient, but if I have a patient with thoracic trauma or who's already unstable and now making them pant like crazy, I don't love using it. If that's your only option, fire away. There's nothing wrong with it. For me, butorphanol is a sedative. I don't really think it has any pain control. It might have a little, but if that's all you have, it's better than nothing. Other things you can consider, things like NMDA inhibitors like ketamine. It's a great pain medication. It not only helps with pain, but it helps with wind-up pain or anticipatory pain. Easiest way to describe that is you hurt your knee, the doctor's about to touch it, and it hurts way more before they even touch it. That's wind-up or anticipatory pain. You give a patient ketamine or the oral form amantadine, it's a great drug. Lidocaine, reminder, 25 mic per kg per minute to 35 mic per kg per minute. That's pain control. We put colicky patients on that all the time, post-operative GI patients on it all the time. The thought is by affecting those sodium and potassium channels, it's actually blocking the pain sensation. So it's another good one. It's not just a local anesthetic. Gabapentin, pregabalin, if your patient's able to swallow, those are also great things to consider. How about NSAIDs? No, no, no. Steroids? No, no, no. Why? Remember we earlier talked about perfusion. Your body needs prostaglandin, which is what these guys are inhibiting. Why? Prostaglandin increases renal afferent artery perfusion. So it increases blood flow to your kidneys. It also increases mucus production in your stomach. It also increases blood flow to your GI tract. You take a shocky patient and you shut off the blood flow to the kidney, great. If you shut off blood flow to the GI tract, now you will definitely have shock gut. If you notice on this arachidonic acid cycle, again, I'm going to do a faux pas. On this side here is your COX system, cyclooxygenase. So that's going to be your prostaglandins, prostacyclins, and thromboxane A2. Prostaglandins are going to be your pain guys. Thromboxane A2, that's what helps your platelets stick to each other. So it helps you clot your blood. That's why they tell us when you have chest pain to take an aspirin. You're going to keep those platelets from sticking to each other. It's another reason you don't want to give an NSAID to a trauma patient. You may increase bleeding. Steroids, they block at the top part, which is, so it's cutting off that side and the leukotriene side, which is the white cell line, which is why we can use it as an immunosuppressive. But this is why you don't want to use steroids in any shocky patient. The only patients that I ever use steroids in when they're shocky, no Addisonian, a patient that may be in anaphylactic shock, and that's arguable whether or not it should even have it, or a patient that was on a pred taper, they had trauma. I'm not sure if they have relative adrenal insufficiency or not. I might give it to that. I can count on my hands the number of times I've given steroids to a shocky patient. They're dangerous, especially in some of the doses that you'll see in textbooks. I used in a non-shocky patient, 0.5 mg to 1 mg per kg pred equivalent at DexSP. You will see 8 mg per kg written in some books. So just say no to steroids, but definitely don't use high doses like that. Here's just some of the information we talked about. Common pitfalls in trauma patients. We sedate or try and get them into surgery too soon. Again, I don't have a problem with things like midazolam and methadone and fentanyl and ketamine to take the edge off, keep them calm, relax them. But I want them to be perfusing the best we can. So I want to avoid things like acepromazine, dexdome, phenothiazines of other flavors. Why? Because again, those guys cause a change in your blood flow. They're going to cause reduced blood flow to your kidneys, and they can also make things worse. Yes?
What's your preference, your first choice for pain control of these trauma patients, and which one works the quickest?
I personally love methadone. Reason being, it's a really good pain control. It's a pure mu, but it also has some NMDA inhibition as well. So it does help some of that anticipatory windup. Very rapid, fast acting. Fentanyl technically is the fastest acting. You give a bolus, it's boom. Fentanyl's expensive, and you go through higher doses and higher volumes, and it's not something that a lot of people want to keep in their hospital for unfortunate people stealing reasons. But if I were to pick one opioid that I would have if I had a choice, it would be methadone. And like I said, it's simply because it's very effective, it's very reliable, it's fully reversible. Anything else on that end, guys? Because that is an awesome question. Again, if you only have hydro or you only have, Buprenex or something, I'm fine with that. I want them to get a narcotic at least. Quick thing on septic abdomen. So sometimes we do have traumas that are penetrating into the abdomen. And so this is a really good example of a pneumoperitoneum. That's a patient I am taking to surgery ASAP. Here's why. If one of the ways you can look, sorry. As far as physical exam goes, we found that in order for you to feel a fluid wave, that patient needs to have at least 40 mils of fluid per kilogram of body weight. I think some of the vets that have been doing it longer probably can feel it at way lower numbers, but if you go by the books, you need 40. In order to even see it on a radiograph, you need close to 9 mils per kg before you start seeing that haziness. So those are not always reliable indicators. A lot of us now are using these bedside ultrasounds. You could see fluid at less than 1 mil per kg at that point, but again, not everyone has them yet. So one of the things that you can do that's fairly simple is if you have an effusion, and this works for trauma and non-trauma. If you take a blood sugar from the periphery and then take a blood sugar from that fluid, if you have greater than a 20 milligram per deciliter difference, that is very highly indicative of a septic abdomen. Similar with lactate, lactate in the belly will be way higher than in the periphery. Why? Bacteria love sugar and bacteria use anaerobic glycolysis. So the lactate will climb, the sugar will drop. In theory, if your patient's blood sugar is 120 and your sample is 100, it becomes tough to know exactly. If you have a hypoglycemic patient, it's impossible to know. But if your patient's blood sugar is 200 and the fluid is 50, that's someone that I'm thinking really quickly about, we need to get in there. The antibiotic thing. So I've also given multiple lectures on multi-drug resistant organisms and antibacterial stewardship. I think veterinarians and human physicians alike have created these monster bugs because we've just been trained to give everything a penicillin, amoxicillin, or other. I don't use antibiotics very often, ironically enough. There are a lot of my patients, even surgical patients, that don't get an antibiotic. But if you think you have a septic patient, for every hour delay in appropriate antibiotic therapy, you have an 8.5 increased risk of dying. So multiply that by 5. You have a 40–50% increased risk of dying because you didn't give them an injection of antibiotics. If you know for a fact you have a septic patient, give it. If you're one of those like, not sure, I'd rather you give a dose of ampicillin, for instance, and then say, oops, all right, we didn't need that, than the opposite. As far as specific septic abdomens, they need tons of fluid. Definitely pain support. Again, ideally a pure mu because we can reverse it or we can stack things. Whereas if you give, for instance, Buprodex, and then I need to amp up and start fentanyl or methadone, that mixed portion of it is actually going to reduce the amount of pure mu agonist that we have there. We can overcome it, but it does lessen some of that effect. Antibiotics. So in human studies, they found it is acceptable to delay antibiotics for up to 45 minutes if you're going to surgery. Meaning, if you know for a fact the surgeon's going to be there within 45 minutes and you want to get this sample from in the abdomen and culture that, that's acceptable. However, they have shown that starting empirical antibiotics probably are not going to change what that culture tells you in that short of a time. So I do not wait to start a septic patient on antibiotics. I might take that fluid and put it in a culturette tube, but then I'm hitting them with antibiotics. As far as pressors, I am a huge fan of norepinephrine. Reason being, it's a very good pressor agent, but it also increases right end diastolic filling volume and right ventricular contractile volumes. So it's not only increasing your pressure, but it's also increasing your cardiac output. I personally like it, but if you don't have it and you have dopamine or any of the likes like that, that's fine too. Again, septic peritonitis, get in the surgery ASAP. Try and keep that blood pressure up as high as you can, ideally over 60. Do not hold back pain meds. Yet again, definitely don't use Dextome and acepromazine and things like that. Same reason, you're reducing blood flow to an already traumatized patient. This last bit, again, I know Phil mentioned about me being on the DEI board. I don't know why things have gotten as bad as they have recently, but we are all the same. We're all equal. I don't care race, creed, color, sexual orientation. Treat people the way they should be treated, especially in our field. We have way too high of a rate of suicide. If we don't take care of each other, no one will. And do not be afraid of mental health.